This conference will now be recorded.
Students, can you see the slides?
Yes, sir.
Okay, so today we're going to talk about plasma cell disorders. In the previous classes, we discussed about leukemias, lymphomas, NHL, HL. Then we discussed about myeloproliferative neoplasms. Now we're going to discuss about plasma cell disorders. So today's objective is to introduce the terminology used in describing the plasma cells neoplasm, to explain the physiology of the normal cells and the pathological effects of their neoplastic growth, to describe the classification of plasma cells neoplasm, and to discuss relationship with amyloidosis and its pathology. So this is all going to be in brief as per your schedule in Davidson. Firstly, plasma cells, what are they? The terminally differentiated B lymphocytes that are capable of producing immunoglobulins. So B lymphocytes that do not have a purpose will be terminally differentiated into plasma cells that have a purpose. And that purpose is producing immunoglobulins, which play an important role in acquired immunity and adaptive immunity in response to an infection or to a response to a vaccination to give into your body. So what is a paraprotein? Paraprotein. Paraprotein is a structurally identical and homologous Ig immunoglobulin of the same clone. So that is, it's monoclonal. So it's only one particular clone and one particular identification, one particular function. That's called a paraprotein. It's structurally identical and homologous of the same clone. So what is a lymphoplasmacytic neoplasm? It's the neoplasm of the plasma cells producing excess paraprotein. So now paraproteins are produced in stimulation to some sort of infection or some physical stimulus to the human body. When you have a lymphoplasmacytic neoplasm, there's uncontrolled proliferation. So it's a neoplasm of the plasma cells. So excess paraprotein will be produced, which leads to certain symptoms that we're going to discuss in the next few slides. Coming to classification of plasma cell neoplasms, you have three here, the main three ones that we are going to discuss in terms of differentiation. The first one is monoclonal gammopathy of undetermined significance. So it has undetermined significance, undetermined differentiation, and the amount of plasma cells are less than 10% in the bone marrow. So that's why it's called monoclonal gammopathy of undetermined significance. The second one is an important entity called multiple myeloma. The third one is macroglobulinemia. So this means there are a lot more cells, a lot more plasma cells, and a lot more antibodies in this particular subset of classification of plasma cell neoplasms. Moving on to the next slide. Sorry, that was the previous slide. So first one, monoclonal gammopathy of undetermined significance, MGUS. Here there is an M protein. Sorry. Here there is an M protein presence. It's stable. The levels of M protein, IgG less than 3.5 grams, IgA less than 2 grams, light chains less than 1 gram per day. Normal immunoglobulin levels are there, and then normal immunoglobulins are there. Marrow plasmacytosis less than 5%. Sorry, it was not less than 10%, less than 5%. Complete blood count is normal. There are no lytic bone lesions, and then there are no signs of disease. So essentially, these patients are asymptomatic. They have marrow plasmacytosis less than 5%, and then levels of M protein of IgG less than 3.5, IgA less than 2 grams, and light chains less than 1 gram per day. And there are normal immunoglobulins, normal levels. There are no lytic bone lesions and no signs of disease, unlike multiple myeloma. The M protein is seen in 3% of the people greater than 70 years of age, and 15% of the people greater than 90 years of age. MGUS is diagnosed in 67% of patients with an M protein. 10% of patients with MGUS develop multiple myeloma. So this is a disease that is probably a prequel to multiple myeloma. So coming to the other end of the spectrum, macroglobulinemia. It's a tumor of lymphoplasmacytoid cells producing monoclonal IG immunoglobulin, most commonly IgA. So the types are essential macroglobulinemia and Waldenstrom's macroglobulinemia. So these are two types here. Clinical features are weight loss, fatigue, just like any other cancer cachexia, bleeding sometimes and usually epistaxis will be seen, bone marrow infiltration by the lymphoplasmacytic cells, which are less mature than plasma cells, presenting as anemia, thrombocytopenia, or leukopenia. So these plasma cells are not well functioning, they are less mature, they're undifferentiated, they do not have a particular function, so that is why they may present as anemia, thrombocytopenia, or leukopenia because of infiltration of the bone marrow by lymphoplasmacytic cells. The other useful cells of erythroid, megakaryocytic, and lymphoid precursors will be deficient. So that is why there will be anemia, thrombocytopenia, or leukopenia in macroglobulinemia. So the important entity is multiple myeloma, which is in between these two diseases. So the definition is it's a B cell malignancy characterized by abnormal proliferation of plasma cells able to produce a monoclonal immunoglobulin, so M protein. So it's an abnormal proliferation of plasma cells which are able to produce a monoclonal immunoglobulin. The incidence is 3 to 9 cases per 1 lakh population per year. It's obviously more frequent in the elderly because it's a neoplasm. There's modest male predominance. Males are more affected than females. And it is the second most common adult hematological malignancy. Second most common adult hematological malignancy. The clinical forms of multiple myeloma, there is multiple myeloma, there is solitary plasmacytoma, and then there's plasma cell leukemia, which is a full-blown plasma cell leukemia. M protein is seen in 99% of the cases in serum or urine. IgG is greater than 50% in composition. IgA is 20 to 25%. IgE or IgD is 1 to 3%. Light chains are about 20%. So 1% of the cases are non-secretory. The others are secretory. Only 1% are non-secretory. Here, M protein is very specific. It's seen in 99% of the cases in serum or urine. The clinical manifestations are related to malignant behavior of plasma cells and abnormalities produced by the M protein. So because of plasma cell proliferation in the bone marrow, there will be multiple osteolytic bone lesions. So plasma cells in the bone marrow will produce these osteolytic bone lesions. There will be hypercalcemia because of PTH production, and there will be bone marrow suppression because of pancytopenia. All the other bone marrow cells will be suppressed because of the plasma cell proliferation. And there will be a monoclonal M protein, decreased level of normal immunoglobulins, and more number of M protein clones will be seen. Because of this excessive production of M protein, there will be hyperviscosity of the blood. Hyperviscosity of the blood, which can lead to formation of thrombus or can lead to stroke. So there are multiple complications of multiple myeloma. Going to clinical symptoms, you have bone pains, pathologic fractures because of the involvement of the bone, weakness and fatigue, just like any other cancer. Serious infections can occur because of pancytopenia, which will also have neutropenia. Renal failure can occur because of deposition of calcium in the kidney, leading to renal failure. And then bleeding dialysis because of thrombocytopenia. So bone pains, pathological fractures because of plasma cell proliferation in the bone marrow, leading to osteolytic lesions, weakness and fatigue because of cancer cachexia, serious infection because of neutropenia, renal failure because of deposition of calcium, and bleeding diathesis because of thrombocytopenia. These are the common clinical symptoms of multiple myeloma. Next, we have laboratory test. ESR is greater than 100. Erythrocyte sedimentation rate will be increased. Anemia, thrombocytopenia might be seen in the peripheral smear. Rowland's formation in peripheral blood smears can also be seen because of the increased viscosity of blood. Myeloplasmacytosis greater than 10 to 15% here. Whereas in case of MGUS, it will be less than 5%. There will be hyperproteinemia because of increased production of immunoglobulins. Hypercalcemia will be seen. Proteinuria will be seen, loss of protein in the urine, and azotemia, renal failure leading to ammonia deposition, ammonia accumulation in the body. Here you see a bone marrow smear. This is a bone marrow biopsy of multiple myeloma. You can see the proliferation of plasma cells here. These are the plasma cells here. These are lymphocytes and these are plasma cells. Next slide. You can see the lytic bone lesions here, punched out lesions in the skull, hair on end appearance. It's called lytic bone lesions in myeloma. Even the next slide also shows the same thing. Here you see a lateral skull X-ray with typical findings of multiple myeloma with multiple punched out holes. The arrow is pointing at one of the larger holes. This is the larger holes. So these are multiple punched out lesions. This can be seen in multiple myeloma. You can see a spinal radiograph showing generalized osteopenia and multiple compression fractures. So osteopenia, normally this is all more white here. Bone is more white, it's more radio opaque. You can see white here, but because of this translucency, this is osteopenia. This translucency is osteopenia. This is a electrophoresis of the serum or urine, protein electrophoresis. You can see this is an M spike. Normally the M protein is only of this much level, but you can see this spike. This is called M spike. This protein bands, the direction of electric current is like this. So this is the protein electrophoresis of the serum or the urine. The next picture is also the same thing. Normally what you find is this albumin is seen like this. Coming here, this is the M protein. M protein is normally this level, but in multiple myeloma it's elevated. Serum electrophoresis. So obviously, because now I have put all these pictures, that means that multiple myeloma requires this particular plasma cell proliferation in the bone marrow, lytic bone lesions, and it requires protein electrophoresis. It requires protein electrophoresis. So obviously, the diagnostic criteria for multiple myeloma is a major criteria: plasmacytoma on tissue biopsy or bone marrow plasma cells greater than 30%, which is very specific. Monoclonal M spike on electrophoresis, that is IgG greater than 3.5, IgA greater than 2, and light chains greater than 1 in 24 hours urine sample. Whereas in MGUHS, this particular thing, IgG less than 3.5, IgA less than 2, and light chain less than 1, with bone marrow plasma cells less than 5%. So that is MGUHS, monoclonal gammopathy of undetermined significance. But here in major criteria for diagnosis of multiple myeloma, you have plasmacytoma on tissue biopsy, bone marrow plasma cells greater than 30%, monoclonal M spike on electrophoresis, IgG greater than 3.5, IgA greater than 2, light chain greater than 1 in 24 hours urine sample. And the minor criteria, as bone marrow plasma cells 10 to 30%, we come into minor criteria. M spike but less than above, so less than this, and lytic bone lesions. Normal IgM less than 50, IgA less than 100, and IgG less than 600. So per day, not in just 24 hours. So this is the lytic bone lesions comes under minor criteria. So what all include? So just like you have Jones criteria or you have Duke's criteria in case of rheumatic heart disease and infective endocarditis, where you have two major criteria or one minor criteria, one major criteria plus three minor criteria or five minor criteria. So just like that, here you have multiple combinations. Now it's easy. Major criteria 1, 2, 3 and minor criteria A, B, C, D. So the next slide shows this. So it's either diagnosis is 1 plus B, 1 plus C or 1 plus D. That means it has to have one major plus one minor. So 2 plus B, 2 plus C, 2 plus D, 3 plus A, 3 plus C, or 1 or 2 plus D, A plus B plus C, A plus B plus D. So it has to contain either 3 minor criteria or 1 major and 1 minor criteria or 2 major criteria. So here you have 1 plus B or C or D, 2 plus B or C or D, or 3 plus B or C or D. So that means there has to have an M spike or a lytic bone lesion or normal IgM less than this amount. So that is the diagnostic criteria. For just simple terms, just consider that if you have a bone marrow plasma cell greater than 30%, if you have a monoclonal M spike on electrophoresis, and you have lytic bone lesions, you can consider this as multiple myeloma. So just making it easier. So the next one is clinical staging. It's based on the level of hemoglobin, serum calcium, immunoglobulins, and presence or not of lytic bone lesions. It correlates with myeloma burden and prognosis. There's one is low tumor mass, two is intermediate, three is high tumor mass. Subclassification A is creatinine less than 2, and B is creatinine greater than 2. So obviously B is more, it's worse and it has a worse prognosis. So this is a staging of multiple myeloma. You don't need to remember this, it's just for prognosis sake. So next one. This is a picture from Davidson itself. Here you have multiple manifestations of multiple myeloma. There's hyperviscosity leading to retinal bleeds, bruising, heart failure, cerebral ischemia. You have amyloid deposition leading to panda eyes, nephrotic syndrome, carpal tunnel syndrome, bone pain or fracture. Lytic lesions can be seen. These are the lytic lesions that we have discussed before. Renal failure due to paraprotein deposition or hypercalcemia, infection, NSCDs and amyloid deposition. Spinal cord compression can be seen because of bony collapse or extra durable mass. Here you have enlarged retinal veins and hyperviscosity. They can be seen here. These enlarged retinal veins. Abnormal blood tests like anemia, normo, or macrocytic pancytopenia will be seen. Raised ESR, hypercalcemia, renal impairment can be seen. Paraproteinemia, immune paresis can be seen. Here you have Benz-Jones proteinuria that is also characteristic of multiple myeloma. That is light chain proteinuria is called Benz-Jones proteinuria. And then bone marrow plasmacytosis greater than 30%. These are the plasma cells in bone marrow. So these are all the clinical and laboratory manifestations of multiple myeloma. Just summarize it. This is just for summary's sake. So what are the poor prognosis factors in multiple myeloma? You have cytogenical abnormalities of 11 and 13 chromosomes or beta 2 microglobins greater than 2.5 microgram per ml. So these are the two more prognosis factors for multiple myeloma. Cytogenic abnormalities of 11 and 13 chromosomes and beta 2 microglobulins of greater than 2.5 microgram per ml. So next one is treatment. Treatment is not that simple, but we have only certain group of drugs for this. Patients less than 65 to 70 years, patients greater than 65 years. Now here you have high dose therapy with autologous stem cell transplantation. You have allogenic stem cell transplantation, conventional and mini. Conventional is normal when there is myeloablative therapy before giving the transplantation, and then you go for allogenic stem transplantation. Mini is when you do not give myeloablative therapy. So patients greater than 65%, you can go for conventional chemotherapy. So high dose is fatal for them, so you should go for conventional chemotherapy and non-myeloablative therapy. You shouldn't destroy the bone marrow before transplanting the allogenic transplantation. This is called mini transplantation. This is called conventional transplantation. So in patients less than 65, you have to go for high dose therapy with autologous stem cell transplantation or allogenic stem cell transplantation, which has myeloablative therapy also. Greater than 65 years, go for conventional chemotherapy and non-myeloablative therapy with allogenic transplantation. So no myeloablative therapy. So conventional chemotherapy consists of melphalan, prednisolone. This is the first drug that have been introduced, melphalan and prednisone. And then there's an M2 one that's vincristine, melphalan, cyclophosphamide, carmustine or PCNU, and prednisone combination. And there's a wide combination. It's called vincristine, atomycin, dexamethasone. You just need to remember melphalan plus prednisolone. This is the most important one, and that you can add cyclophosphamide or atomycin later when there is necessary. Response rate is 50 to 60%. The long-term survival is only 5 to 10% in patients. So this is with conventional chemotherapy. The next one is autologous transplantation. Patients less than 65. Treatment rate in mortality is 10 to 20%. Response rate is 80% here. Long-term survival is 40 to 50%. So good response and good long-term survival. In conventional allogenic transplantation, patients less than 45 to 50 years with HLA identical donor. And treatment rate in mortality is 40 to 50%. It's obviously more. And long-term survival is less than autologous transplantation. It's 20 to 30% because it's taken from a different person. So that is about transplantation in multiple myeloma. So the new method is non-myeloablative therapy and allogeneic transplantation, and also thalidomide. Thalidomide is not being used before, now it's being used for multiple myeloma. There's also bortezomib, it's a protease inhibitor that's being used now. Bortezomib, Bortezumab. So the last one is supportive treatment. You have bisphosphonates and calcitonin for hypercalcemia, for treatment of hypercalcemia. They give recombinant erythropoietin for treatment of anemia. So you have to stimulate blood cell production and you have to increase the erythroid precursors in RBCs, sorry, in the bone marrow. So you have to give recombinant erythropoietin. You can give immunoglobulins also for treatment of infections. And then you have plasma exchange therapy or plasmapheresis. In case of hyperviscosity, in order to reduce the number of circulating M proteins or paraproteins, which are of no use except for except for hyperviscosity as a side effect, you can go for plasmapheresis. The last one is radiation therapy in case of metastatic disease and severe disease. You have to go for radiation therapy as a last resort. So that is about the treatment of multiple myeloma. Just going back, sorry. So this is the clinical and laboratory features. This is the poor prognosis factors, 11 and 13 chromosomes, beta 2 microglobules less than 2.5%, treatment less than 65, high dose therapy with autologous stem cell transplantation or allogenic transplantation with conventional and mini. And conventional is usually done in less than 45 years of age. Greater than 65 years, you go for conventional chemotherapy plus mini transplantation. And then you have conventional chemotherapy, melphalan, prednisolone, or you have vincristine, adriamycin, dexamethasone. Response rate is 50-60%. Long-term survival is only 5 to 10%. You have autologous transplantation, which will increase the long-term survival to 40 to 50%. And conventional allogenic transplantation, which will increase the long-term survival to 20 to 30%. The new method is non-myeloablative therapy and allogenic transplantation and thalidomide. There is a protease inhibitor also being used now, bortezomib. Bortezomib is also being used for treatment of multiple myeloma. Supportive therapy in case of hypercalcemia, you can give bisphosphonates and calcitonin. Recombinant erythropoietin for treatment of anemia, immunoglobulins for treatment of infections, plasma exchange for hyperviscosity, and radiation therapy for severe disease. So that is the treatment of multiple myeloma. So coming lastly, what are the disorders associated with monoclonal protein? So first one, neoplastic cell proliferation is seen in multiple myeloma, solitary plasmacytoma, Waldenström's macroglobulinemia, heavy chain disease, and primary amyloidosis. Again, amyloidosis is primary amyloidosis. There will be deposition of amyloid material deposition will be seen in. It can be seen in the heart, can be seen in the kidney, can be seen in the lungs, can be seen in the brain also. So if it's undetermined significance, then it's monoclonal gammopathy of undetermined significance. Transient M protein can also be seen in viral infection and post-valve replacement. Post-valve replacement surgery can be seen. In case of malignancy like bowel cancer or breast cancer, you can see monoclonal protein. Immune dysregulation syndrome in AIDS in the old age, you can see monoclonal protein. And chronic inflammation, you can see monoclonal protein. So these are the disorders associated with monoclonal protein. So just in brief, monoclonal protein is produced from plasma cells which are undifferentiated, and these undifferentiated plasma cells, when they go to a neoplasm, when they proliferate without any limit, then they produce unlimited amounts of M protein, which is of no use. It's only useful for producing symptoms, and those symptoms will be seen in multiple myeloma. And because of that, you can see osteolytic lesions, you can see anemia, thrombocytopenia, you can see neutropenia, you can see pancytopenia, you can see fatigue, you can see weight loss. So all these symptoms will be there. You can go for bone marrow biopsy, which shows greater than 30% plasma cells. You can go for urine or serum electrophoresis, which will show an M protein spike in it, which will contain greater than 3.5 grams of IgG, greater than 2 grams of IgA, and greater than 1 gram of light chains for 24 hours per day. And you can have osteolytic lesions. So this is the diagnosis. This is the way you can diagnose multiple myeloma. Once you diagnose, you go for investigations to look for renal failure, The creatinine is greater than 2, you have a poorer prognosis. Less than 2, it's a good prognosis. Then you start the treatment based upon the age group. Greater than 65 years, you only give conventional chemotherapy and mini transplantation. With less than 65 years, you can go for allogenic transplantation, sorry, autologous transplant and high dose chemotherapy. With less than 45, you can go for high dose chemotherapy and also allogenic stem cell transplantation with myeloablative therapy. And the last resorts are thalidomide, you can go for bortezomib, and that is the end of the spectrum. And these are the disorders associated with monoclonal protein. So yeah, multiple myeloma is quite easy. You need to know what are the causative factors, you need to know the clinical features, you need to know the lab investigations, the treatment, and the significance. So last one is amyloidosis. Primary amyloidosis is when there is deposition of light chain of IgG as in multiple myelomocytes, so tongue, GIT, heart, connective tissue. Secondary amyloidosis is deposition of amyloid A substance in the sites like spleen, liver, kidney. And familial amyloidosis is due to genetic mutation. It's causing deposition of unmetallized prealbumin. So now primary amyloidosis of the tongue can cause bulky tongue, in the GIT can cause bleeding, in the heart it can cause hypertrophic or restrictive cardiomyopathy. Connective tissue it can cause joint pains and other sort of inflammation and skin diseases. Then deposition in the spleen, liver and kidney can produce kidney failure, liver failure and splenic rupture. Not rupture, sorry, splenic failure. Due to genetic mutation, it can cause deposition of unmetallized prealbumin. So these are the manifestations of amyloidosis in brief. So yeah, that is the end of today's class. Thank you for listening. If you have any doubts, you can ask me now. Otherwise, you can end the class. Students, if there are no doubts, we can end the class. All right then. Thank you.